All right, so I know we made the announcement last week, but I know that we've got some different people here. So Dr. Cruz has asked me to let everybody know that we will be sending some more information here shortly. There is a new listserv that we have created. It's in the works, and it is specifically dedicated to professional development. So we'll get that information to you here soon. There is the event code on here with today's date, the phone number if you need that. Next slide. And so this is the Family Medicine Grand Rounds for today, March 3rd, 2021. Again, the event code with the contact numbers. And just remember that if you are wanting CME credit, please make sure that you register before midnight tonight. Next slide. So we would like to thank you in advance for muting your microphone as we begin here, and also being attentive and engaged in this session. Dr. Tenorio has asked that if we have any questions, if we could please put those in the chat box, and we will go ahead and address those at the end of her presentation. And then also I will be putting information in the chat box on how to complete and submit an evaluation for her. Next slide. And this is the South Texas Regional Family Medicine Grand Rounds with our partner, the South Central AHEC, and our department's mission statement. Next slide. For those of you who are wanting CME credit, you can take a look at your transcript at the CME website listed there. And then also, if you have any questions or having issues with your transcript or the CME credit, please be sure to either contact them or you can contact me as well. Also, AAFP credit information is on this slide. If you are looking at AAFP credit, you can contact them or you can contact me as well. So Dr. Tenorio has no relevant financial interests with commercial interest to disclose. So I know many of you are very excited today. We have one of our former residents here to present for us. Dr. Tenorio is coming to us from the Houston Methodist Hospital. She's a palliative care physician and instructor. And so I will let her get started. Her presentation today is on end-of-life care challenges and management.
Thank you so much, Nicole. Hi, everybody. I'm so happy and excited to be here. I'm a bit nervous. I see all my mentors in front of me, so please be gentle. But I'm hoping you'd all learn from my lecture today. So I am a palliative care physician. I'm very passionate about helping patients and families during this difficult time of their lives. So I'm going to try to see what I'm going to provide a lecture to see what I can help you with because we all will have to deal with end of life with our patients. So my objectives for this lecture is number one, to understand why end of life care matters. To identify the challenges encountered during end of life care, describe different end of life symptoms and issues, and lastly, explain different treatment options, management, and approaches. So let me start my discussion by presenting to you a patient case to help make the content of this lecture be more applicable to our practice. Just to let you know, this case is not a real case and just simulated case. So Mrs. E was an 88-year-old female with a significant medical history of Alzheimer's, dementia, hypertension, and asthma. She was diagnosed with dementia at age of 82, but however, 2 years ago, family started seeing her decline. A few weeks ago, she had a decrease in appetite with some intermittent agitation and confusion. She slept during the day, but would get restless at night. One day, she was brought to the hospital due to dyspnea. At the ED, she was immediately intubated due to respiratory distress. So to define end of life care, so what is it? So I always tell families and patients, of course, or everybody, when life begins, of course, life also ends. So when we talk about end of life care, we focus on what we call palliative care at end of life, which is what we call hospice care. So hospice is only part of palliative care, the umbrella of palliative care. So patients who are at end of life deserve to be treated for comfort and to be free of suffering. Regardless of the cause of suffering, palliative care is mostly needed and integrated at all levels of care. So in this slide, it kind of explains why we need palliative care to be integrated at all levels of care. So you can see that this slide emphasizes the importance of providing high value care to patients who are in need of high quality care, but at the same time being efficient and the care being efficient and cost effective. So value in healthcare is actually defined by the ratio of quality to cost. So studies have shown that actually palliative care is really benefits the benefit of palliative care, I'm sorry, is really in providing high quality care and in decreasing costs. So, since we know that most end of life situations involve aggressive treatment and high treatment costs and not entirely providing the quality of care patients deserve at this stage of their life, that means that palliative care, being that it can provide high quality and help decrease costs, is very important as it can help increase the value of care at end of life. That's why palliative care can be integrated at all levels of care. But why is end of life care still difficult? This is a really sad situation in most hospitals because there's a lot of barriers to this type of care. And a few studies have shown that despite increasing access to palliative care, the quality of care at end of life has shown little or no improvement over time. And this is mostly because of a lot of barriers. So I continue with the case. Mrs. E was placed in the ICU but still decompensated. Family continued to hope for patient to get better, and so they continued to want to do aggressive treatment. Patient was started on CRRT due to renal failure, and pressors were started to raise her blood pressure. The family was very distressed due to all issues. Palliative care team was then consulted to assist with goals of care and end of life discussion. So, what are the barriers to quality palliative care? Here are some of the things that could be barriers to quality palliative care. I listed them here as these are the ones that would be mostly addressed for the purposes of this presentation. There are a lot of barriers to quality care, but I want to just emphasize these. So, for the purpose of this grand rounds. So, to name a few, barriers include inadequate training of staff, resistance from family members who change the goals of therapy due to unrealistic expectations, ICU care still encouraging continuation of therapy, lack of education of staff, patients, and family, and lack of communication. I want to emphasize, though, that even though these are barriers, we can always do something to improve quality of care. And I want to let everybody know that please do not let these barriers keep you from providing quality of care. Quality care, I mean, we can still do something about minimizing and eliminating these barriers. Um, and also, I wanted to highlight, I missed a slide here, but I was supposed to highlight the last two, which is lack of education of staff, patients, and family, and lack of communication, because I was going to talk a little bit more about that. So, how can we improve training and education to help minimize the lack of education, which is a barrier? There have been studies that have been done that have incorporated palliative care in certain curriculums, both in the nursing and the medical curriculum residency. So here are some examples of a nursing curriculum. They incorporated palliative care, and one study has shown that some nursing students actually develop greater compassion and increased decision making. There was also another study where there was a pre and post study that showed nurses had actually had an improvement in behavior and the number of conversations with patients and caregivers because they had more increased confidence. There's another study that I saw that with ER residents, because sometimes in a medical care it would be really hard to incorporate palliative care at the ER, but this curriculum actually this study showed that when they incorporated palliative care in the ER with the ER residents, they were able to increase in the perception of these residents of the importance of palliative care in the ED, and they were more confident in implementing palliative care skills. So how can we really improve training and education to help eliminate that barrier? I just would encourage everybody to continue studying, reading, ask questions, be willing to learn. Knowledge is really power. It's actually the power to change for the better. Another important question that we always deal at end of life. So why do we suffer? Why is suffering part of end of life? There are a lot of reasons why it is involved in end of life and can be due to multiple problems. There's high symptom burden, maybe pain, dyspnea, depression, agitation, inadequate emotional support, unexpected financial burden, just lack of communication between patients, families, and providers, disregard for family and patient goals, and actually prolongation of the dying process, which would be refusal to stop therapy by families or providers just continuing the therapy that are also not changing the progression. I continue with the case. So Mrs. E. children kept asking for sedation to be turned off while patient was in the ICU, as they thought that patient's decreased response was only due to the sedatives. However, when sedation was weaned off, the patient would start getting agitated and would become more tachypnic. So sedation had to be placed back again. Later in the day, the oxygen demand increased in patient's chest X-ray showed findings consistent with most likely worsening aspiration pneumonia. So, what are the common symptoms of and issues at end of life? So, I'm going to present here the most common ones. There are a lot of issues at end of life, but I will focus on these common ones for the purposes of this presentation. So, these are the symptoms and issues at end of life that we see a lot. Total pain. And when I say pain, it's not just physical, it's also the spiritual and emotional pain. There's delirium, dyspnea, increased oropharyngeal secretions, fever, and artificial feeding. Yes or no? It's a question that families ask. When we talk about total pain, pain is not just an isolated sensory or emotional experience, which I just said. It interacts with um, the patient's mood, behavior, and social relationships. So there are three parts to total pain. There's physical pain, which may be directly caused by illness, treatment, and comorbid conditions. Existential or spiritual pain, which arises from the impact on a person's sense of control, identity, and justice and meaning. And social pain. It results from loss of position and role within the family and society. When we talk about pain, we still talk a lot more about physical pain. So I'm going to focus on some of the barriers um, that can affect our treatment of pain with patients as we treat patients a lot with, of course, end of life with opioids. So here are some of the barriers to effective pain management when treating patients at end of life. So the barrier may be an inadequate pain assessment by clinicians, maybe inadequate education and training in pain management, the patient reluctance to report pain or reluctance to take opioids, physician provide or provider reluctance to prescribe opioids, or nurse or caregiver reluctance to give opioids. There's also a fear of addiction and a fear of premature death due to respiratory depressant effect of opioids. So I highlighted the seventh and the eighth barrier because this is the one most providers and patients are scared of that actually leads to the above barriers. So I will elaborate on these two further in this lecture. So why do we fear addiction? We know that in our country there's an opioid health crisis. So we know 9.5 million Americans have been diagnosed with substance use disorder. Um, but the question that we have is that, but since hospice patients are dying, why not allow them to continue taking opioids even in the face of substance misuse? Um, World Health Organization recommends actually open-ended dose escalation for dying patients to provide total comfort for patients. But we know that the higher the dose of opioids, the higher the side effects. And we want to recognize substance use disorder as a disease. So we know that even though opioids help eliminate pain at end of life, and an opioid is the mainstay of treatment, we can still try to minimize risks of opioid use and recognize that substance use is a disorder. Just to define certain types of addiction, there's what we call addiction, which is the disease in itself, and it's a neurobiological disease where patients continue to use despite harm or craving. There's also what we call physical dependence, where the patients just adapted to the to the medication where they really need the medication just to be able to function. And we see that a lot in patients who especially have cancer-related pain. And if in physical dependence may be evident in patients where we abruptly stop the opioids and they eventually develop withdrawal syndromes. And so that once the drug goes down, they look like they are addicted to it, but it's not. It's just that they need to be they need to be on it in order to function. There's also pseudo addiction where patients may have behaviors that mimic addiction due to unrelieved pain. And this is because of inadequately prescribed analgesic, leading to demands for more pain meds. I do have had some patients who have been banded as addicted, but I worked really hard with these patients. And because first, if you need to know and evaluate the patient, of course, and determine the cause of pain. And eventually, if the patient leads to a good pain goal, those behaviors that mimic addiction will go away. And if they don't, then that can be concerning for addiction. So how can we minimize risk of addiction? I know in your clinic we use the opioid risk tool. That is one of the things that we would recommend, mostly in outpatients. In inpatient, we use the CAGE. Some clinics in palliative care use the SOAP bar assessments. I'm not going to go elaborate more on that because for interest of time. But the most important thing when you start opioid is to always complete a comprehensive opioid pain and social history. And then once you get all of that, create an individualized care pain management plan for patients identified with risks. I know you all have in your clinic a pain management contract, and always be open to communication with patients and their families. Always be honest with your concerns. So the one question that we have at end of life, is there addiction at end of life? While it is not appropriate to withhold opioids from dying patients, it is also appropriate to take steps to reduce morbidity because we know that these opioids can cause a lot of side effects. Always calculate the risks versus benefits. Ensure dose moderation overall. There are also other non-opioid treatment options, such as, you can use any heating pads for pain for patients, just non-opioids. But if all of those fail and you're really having to increase opioids at end of life, you can discuss with the family the principle of double effect. And what it is, it's that an increased risk of death may be acceptable if it is the unavoidable consequence of a desired outcome, such as improved pain relief or sedation. And that's with hospice care. Okay. And that's something that families need to be educated about when they have when we have patients or their loved ones just having uncontrolled symptoms at end of life. So the other concerning issue that providers have and patients have a fear of is the respiratory depression with opioids. We know that opioids may have a suppressant effect on their respiratory center, but tolerance to these effects develop rapidly and early in the course of treatment. So within a few days, the threshold dose for respiratory depression, far exceeds analgesic threshold. But it's still important to do slow titration and frequent monitoring when giving patients with opioids. So what is the preferred opioid at end of life? It's morphine. Why is that so? Morphine remains the World Health Organization endorsed gold standard opioid, and in most situations is considered the opioid of first choice because of its versatility, clinical experience, and non-inferiority to other opioids. It is inexpensive and relatively available, and due to its short half-life, it can be titrated quickly based on patient response. So there are other opioids that we can give at end of life, but the preferred first choice is morphine, and we use that a lot. So the other component of total pain is spiritual pain. So when patients are coping with chronic diseases, studies have shown that patients usually frequently their coping is influenced by spiritual beliefs. So it is then important to understand that their spiritual needs when they are having a lot of pain. So we know that spirituality is important in palliative care because it can help alleviate suffering regardless of the stage of the disease. And spirituality can also influence the way patients cope with their oh, I'm sorry. Oops, I cope with their give me a second. Spirituality can also influence coping and helps address overall well-being, not only in the face of death. So we do have in our palliative care team our own dedicated chaplain who helps us navigate the difficulties that patients have in our service. Emotional pain is also part of total pain. So our emotional state has an enormous influence on pain. So whenever have a negative emotional state, it can increase pain, whereas a positive state actually lowers pain. And this is experienced by everyone. So when patients have total pain, not just physical, but it's also spiritual and emotional, how can we help? So we do provide what we call expressive supportive counseling, and that's when we have patients just talk about, express what they're feeling. And it's like training as a surgeon, draining an abscess and let that abscess come out and eventually make them feel better. And this has been proven to help patients. Just listening. Seek support from a palliative care social worker or a chaplain, palliative care chaplain. Do spirituality related actions such as prayer. You don't have to lead the prayer, but if the patient asks you to pray with them, just be present, and that can help them. Provide comprehensive care and impart meaning to the work of palliative care professionals, meaning let the patient and families know that that's what that we as providers are there for, is to help. And humanize death. When I say humanize, it makes to make the dying process a natural part of life. Explain to families that they're not alone in going through this. Again, tell them when life begins, life also ends. It's not easy, but we are here to help and guide them. Another symptom is delirium that is very common at end of life. So I move on from pain to delirium now. So, terminal delirium is part of end of life. It's a global brain dysfunction and it is irreversible. Of course, when patients present with delirium at the hospital, we as providers and physicians, we try to reverse try to determine the irreversible causes of delirium. But if patients are at their end of life, delirium is irreversible. We see positive symptoms most of the time, but there's also hypoactive symptoms. When we say positive, it's mostly hyperactive. But then patients, when they're at their terminal stage, they transition to hypoactive delirium, which is mostly just, in a comatose state. And delirium is so how you see the patients first having hyperactive, then hypoactive and persistent comatose state, and then the next would be death. I'm going to talk about really briefly about medical management of delirium of end of life. We do provide antipsychotics as the first line for delirium at end of life, and haloperidol is our first line medication because it has a few anticholinergic effects and fewer active metabolites and relatively small risk of hypotension and extrapyramidal symptoms. There are, of course, second generation antipsychotics. They have the same effect but are more expensive. Here in the hospital and in hospice, Haldol is given because of Haldol can be given sublingually in an IV. Olanzapine and quetiapine are mostly oral, so we don't really use them a lot at end of life. Risperdal is I also has IV form, I believe, but we don't use it. So because we have Haldol. Uh-huh. Benzodiazepines also can be given, but we need to use them cautiously as they can cause a paradoxical agitation and worsen the symptoms of delirium. But there have been studies with terminal delirium that cannot be controlled with Haldol. There have been a few studies that shown that a combination of benzos with Haldol can actually help give some relief to patients. Chlorpromazine or thorazine can also be given a second line if more sedation is needed. So we used that a lot back when I was doing training at MD Anderson Cancer Center when Haldol wasn't working, we start with Thorazine, because it helps with more sedation. But the hard part there is that it takes a while for it to be delivered to the unit, and how it's being delivered it needs to be delivered slow IV. So you just have to see what would benefit patient and see how you can really rapidly titrate the medications to give patient relief. So this is a table of some of the medications that I just mentioned, and I wouldn't go into much detail about that, but with Haldol, we usually start off, if we have concerns about terminal delirium and agitation with patients, we usually recommend scheduling Haldol 1 to 2 milligrams IV every 6 hours to start with if the patient is constantly having agitation. But if it's a mixture of hyper and hypo, we just recommend PRN. Lorazepam is what we use mostly for end of life, and we start by maybe just giving 1 milligram. The next symptom of end of life is dyspnea. Dyspnea occurs with disease progression due to, just mismatch between respiratory drive and lung compliance. When patients at end of life experience air hunger, it may be a sign of increasing carbon dioxide retention, or maybe a sign of patient not being able to get rid of air. So how do we help patients going through dyspnea at end of life? So at end of life, opioids is the mainstay of treatment that can help dyspnea at end of life. So we know that opioid receptors are found to be in high concentration in the brainstem, which can give an inhibitory influence on the inspiratory drive. Opioids also are known to have anxiolytic properties. So we give, again, morphine for not just for pain at end of life, but we also give them for dyspnea. It helps the brain dissociate from the lung, and the perception of the patient will be like, even though their lung is having a hard time, they won't feel like they're drowning or hungry for air. So I got this table from American Thoracic Society of End of Life because really opioids for dyspnea for patients who are not close to hospice care or not at end of life can be given to patients who are on, let's say, end stage COPD, and these are some of the doses that they give for those types of patients for oral. But with end of life dyspnea and patients in hospice, we usually not give oral anymore because most of the patients are not really able to swallow at that point, and we do start with IV. And these would be appropriate doses to start with. Other medications for dyspnea, benzodiazepines also, because it can help diminish anxiety. Antipsychotics can help because it can help with that. Steroids sometimes can also help because it can help decrease inflammation in the lung. And so even though a patient, let's say, is at end of life and steroids you need some time to see the effect of steroids. If a patient's still expected to live like a little bit more than a week, then sometimes a steroid can help. There are non-medical management of dyspnea, handheld fans. There has been a study that actually showed a decrease in dyspnea with a fan to face. The Cochrane review didn't really show any significant benefit, but we've provided some patients with fans to face, and they liked it. And so it's just mostly a case-by-case basis. If the patient doesn't see any relief, then just stop it, because there's no harm in starting or stopping it. Oxygen, it's very useful for patients who are hypoxemic, but not really useful for those without hypoxemia, but can be given for comfort affecting perception. But it doesn't reverse the patient's condition. If you patient is actively dying, usually oxygen won't really benefit. We give it sometimes still, like a next nasal cannula, low dose, just to provide some comfort, not just to the patient, but to the family too, seeing the patients being given oxygen. The next symptom is respiratory secretion. So respiratory secretions increase because it's part of the process of dying. There's an impaired cough and gag reflex. The we lose the ability to clear the secretions. We're not able to protect our airway from aspiration as our muscles weaken and so is our ability to swallow. So the saliva gets pulled in the posterior pharynx, and the retention of the secretions in the tracheobronchial tree can lead to noisy respirations. We call it rattling, gurgling, crackling, and it's also usually called the death rattle. Try not to say the death rattle in front of families, but some of them know what it is. They actually bring it up to me, and I say, yes, it's the rattling, gurgling sound at end of life. Does it cause patients discomfort? The studies have shown that they don't actually cause discomfort for patients, but we still treat them to minimize secretions. Why is that so? Because here families, if they hear the sound, it causes them distress. And as palliative care physicians, our goal is to address the family's concerns. So we educate, we tell them it doesn't cause distress to patients unless they're showing that they're having any difficulty breathing or rapid breathing or facial grimacing. And we still provide just to see how much we can minimize the secretion to minimize the distress to families. There's also non-pharmacologic treatment modalities for increasing respiratory secretions by repositioning the patient and just gentle suctioning. So anticholinergic medications are the agents of choice for treatment of copious secretions at end of life. Here at the hospital, we give mostly glycopyrrolate because it's in the only one in IV form. Atropine is the other one that hospices can give because it's the ophthalmic drop can be put under sublingually, and these are the recommended doses. Keep in mind that some hospices give scopolamine patches instead, but it takes a while. It takes about 12 hours, the time of onset, and needs to be replaced every 3 days. Not like atropine and glycopyrrolate, their onset is fast. Also, keep in mind that hyoscyamine glycopyrrolate do not cross the blood-brain barrier, so there may be a decreased risk of delirium in patients. But if the patients are at end of life, we just give whichever one is available. Mhm. The next issue, I know I mentioned fever in the slide earlier. I meant to take that out because I didn't have fever but I'm gonna jump now to artificial feeding. One of the issues at end of life is, do we need to continue feeding patients who are transitioning to their end of life? This is a very controversial subject, and most studies have actually shown no benefit, and it does not actually stop or reverse the declining process that has already started in patients. There's no improvement in life expectancy, tumor response, or toxicity. And there has been studies that have shown that the cessation of eating and drinking simply mirrors the normal process of dying of old age, in which in turn confers to natural analgesic and satiating properties. And that it consistently shows that patients without hydration at end of life die comfortably and do not suffer. So decreased appetite is like dying of old age. When families ask, aside from artificial feeding, can we give IV? And we also, and those also don't actually provide much benefit to patients at end of life. And how I educate patients and families is that, when the body shuts down, the IV fluid can go to dependent parts of the body and can actually lead to more discomfort in patients. So these are some of the discussion points that I would recommend when talking to families about artificial feeding at end of life. I would recommend saying, anorexia is part of the disease process. Decreased appetite is a natural process of end of life. Patients do not actually starve, as starvation is related to the lack of needed calories. When we get hungry, it's our brain triggering for us to eat more so that they can process the food to make, to metabolize to make us feel better. We don't recommend force feeding because it can lead to nausea, discomfort, aspiration with associated respiratory distress. And as I mentioned earlier, you can just mention also again to them, artificial nutrition and hydration can cause more suffering because it can lead to nausea, vomiting, that can lead to aspiration, and with the fluid can lead to pulmonary congestion. So I continue with the case. So family meeting was held with patient's children, the ICU team, and the palliative care team. The natural progression of disease in patients with dementia was explained. Discussion focused on explaining that aggressive treatments will not reverse the disease progression. End of life comfort care hospice was discussed as an option to provide their mother with a dignified and peaceful passing. Family expressed appreciation for the discussion. They decided to withdraw all care and focus on treatment for comfort care at the end of life. One of the questions that I normally get asked is, well, how do we know if death is impending? How do we know that the patient is going to die? And it can affect providing prognosis. There has been a study that was done back in by the MD Anderson team where they listed the different clinical signs of impending death. You can see here apnea, periods, change, strokes, breathing, death rattle, dysphagia of liquids, decreased level of consciousness, decreased performance status, peripheral cyanosis, there's pulsosis of the radial artery, respiration with mandibular movement, just opening the mouth breathing, and decreased urine output. So I listed these symptoms down, and in their study they saw that 7 days before patient died there would be a decreased level of consciousness and the performance scale would be lesser than 20%, and there would be difficulty swallowing. However, in the last 3 days of life, they would see most of these, not all for some, but most. Apnea, chain strokes, death rattle, peripheral cyanosis, decreased radial artery pulse, and mandibular movement and decreased urine output. However, it is also important to note that in this study, they were able to determine, if you can see the 5 symptoms that I highlighted, that 5 of these physical signs were associated with the high likelihood of death within 3 days. But it's also important to note that the absence of these symptoms, however, do not signify that the patient is not going to die within the next 3 days. You just can't determine, with how end of life is. Patients can have an event that may make them decline all of a sudden without having these symptoms. But the presence of these signs can be informative and may assist clinicians in formulating the diagnosis of impending death. So within 1 to 3 days. Mhm. That's the most I've ever seen a study be able to be, that's the most accurate we can get based on this study. So I continue with my case. So palliative care team assisted with withdrawal of care in the hospital together with an external hospice team. The family agreed to that so that hospice can continue to follow up with family for bereavement support. Patient was then medicated with morphine, Haldol, but due to persistent agitation, Lorazepam was added. Patient started to have a lot of oropharyngeal secretion soon after extubation, so glycopyrrolate was given. Patient eventually became comfortable after a few minutes and eventually passed away peacefully after a few hours after withdrawal. So the patient passed. I know, especially this past year with the COVID, I've seen more deaths than I've ever had in my years of practicing palliative care. So here are some tips on maybe how we can deal with the patient death, because it's never easy. We do, because we all care for patients at end of life, and it can be emotionally exhausting, can lead to feelings of guilt. Did I do something wrong? Did I not do it right? Did I contribute to the patient's death? Feelings of hopelessness, failure, and grief. We play a huge role in end of life care, so we cannot afford for everybody to burn out because of this. Here are some of the tips I can recommend. you need to treat the patient death as a learning experience so that the next case will not be as difficult. Debriefing is important. You need to debrief with someone who has had a similar experience in the past, as this can help you reflect on your experiences and see where you could have made changes or think about what you have done or what you could have done better, or what you did really good for the patient. Observe an experienced physician or any healthcare provider that can be a valuable resource. So when we talk about valuable resources, just talking to those people can actually help validate your emotions and help you also reflect on what happened. And it's also important to celebrate those moments where you were able to help patients and families in a good way, is we can't just deal with all the we can't just focus on all the negative things in our profession. We need to focus on the good things too. Proper self-care is important. You need to realize it is self-care is a coping strategy that every healthcare provider should have in order to ensure that they do not burn out easily. Realize that faith can play a role in dealing with difficulties. Doesn't have to be, something, we have doesn't have to be associated with a certain religion. Just have faith and believe that on something and hang on to it, because it can help you find your existential purpose in life. Crying may be viewed as unprofessional, but it has been viewed by patients and families as a sign of devotion and compassion. And just remember that we are all also only human. We are not perfect, but we try our best. Being human is one of the greatest assets you can offer your patients. I know that was a lot, but here's a summary of main points. So end of life care matters because patients who are at end of life deserve to be free of suffering and be treated for comfort. End of life care can provide high quality care, but at the same time, can decrease extraneous medical costs. There are numerous barriers to providing quality end-of-life care to patients, but education proves to be the most helpful way to minimize these barriers. Symptoms of suffering is common at end of life, but the current management of symptoms at end of life are proven to be helpful and safe. Here are my references, a lot. Feel free to reach out to me for any questions or concerns. I know I asked everybody to place on the chat box any questions because I know this is a very controversial topic and might generate a lot of questions. So I'm open to any questions that you all might have. Thank you.
So this is Mark Nato. You were talking about using the second generation antipsychotics at one point.
Yes.
And you listed 3 of them. How do you decide which one you're going to use in any specific clinical situation?
Right. So when we talk about end of life, when I see patients really agitated, just in terminal delirium state, I always start with Haldol. I don't get to use olanzapine and Seroquel anymore because if patient is delirious, it's not safe for them to swallow. But if the situation is really, distressing, I either increase the Haldol or I just start with the Thorazine or I just jump with Lorazepam. And it's hard to really come up with a good protocol for this. I know people ask me, how do you decide which one? There's no exact science. It all depends on how rapidly you need for the patient's symptoms to be controlled. So if you've tried Haldol and you've tried Thorazine, I would just jump to Lorazepam. I haven't really used Risperdal. That wasn't really recommended when I was training, but I don't know of any other palliative physician out there who's using it. Majority of the time, it's either Haldol, Thorazine, or Lorazepam. Sorry, I hope I answered your question. Mm-hmm.
No, that was very good. I appreciate that. I had another question about feeding. I've seen a couple situations where the family wants to feed the person and the person maybe wants to, at least, so it's something they can do together as an activity. Have you had much a positive or negative experience with that?
So are you asking if the patient still wants artificial feeding?
I guess also sometimes the family gets some joy out of it.
Oh, yes. Sorry, I don't know. I thought I put it on my slide. I just remembered that one of the tips I actually would say is that find other means of expressing love to patients. When patients are, they love to eat. But if they are at a point where they're really declining or they really can't eat what they want to eat, then find other means to express your love, because we all know we celebrate with food. One of the recommendations is either to do music therapy or read a book together, do some other activities, and just continue to educate the family that pleasure feeding is still what we recommend when patients are declining and are at end of life. We don't force feed, but we encourage them to eat what they want to eat and not deprive them of what they want to taste when they're close to their end of life. So if they want to drink alcohol, and just a taste of whiskey here and there, and the focus is now on comfort care at end of life, we would encourage that because it's something that the patient would want. And it's one way that maybe we can just a taste, we say if the patient can't swallow, just have it put around the mouth and or the tongue for them to taste it, or ice cream. I hope I answered. Yeah.
Yeah, that was great. Thank you.
Okay. Thank you. Anybody, any other questions?
Dr. Tenorio, thank you so much for a
Oh, hi,
wonderful
Dr.
presentation.
Yes.
It was awesome. It was very
Thank you.
comprehensive and it was very thoughtful. And I love the way you emphasize how we can use our humanity to heal and to be present in that moment and the privilege that it is. So awesome to see you doing all this wonderful work.
I'm so happy to see all of you. Just want to say hi. I'm glad to be back. Thank you for being here, everybody. So
Welcome
again,
home. Welcome home.
yes, I know. I'm gonna share with Nicole, or I know some faculty still know my cell phone. If y'all have any questions about end of life, I am very open to answering any questions, pain management, anything. So feel free to reach out. I hope I was able to help.
Can I ask a quick question regarding the respiratory distress or air hunger? So by giving morphine, I know that will suppress centrally the drive. But at that point, the goal was to make the patient comfortable, right? We're not kind of following up on the O2 stat and things like that to gauge our medication dosing. Is that what the general rule is?
Yes. So really, before I start the opioids for end of life, I need to really communicate with the family. And that's the most important thing, is to talk to the family that these are medications that do have side effects of, decreasing their respiratory drive. But you have to also discuss that principle of double effect, where if you need the medication to provide comfort, it also means that you're ready to accept that there might be, the effect of them declining faster with it in order to achieve the goal of comfort. I tell families who want to still look at the numbers of oxygen saturation once we start comfort care, I talk to them, I recommend for the monitor to be stopped, because I tell them it can actually cause a lot of distress. Instead of you focusing on your loved one, it would be helpful maybe to just turn the monitor off and focusing on being present with your loved one. Because at end of life, what we focus on are not the numbers, but how the patient looks like. Agitation, facial grimacing, restlessness, tachypnea. Usually when I say tachypnea, rate of 20 or less is my goal. If I see that the patient's still breathing fast, then you can say, I can see signs of discomfort at the end of life, I'm going to have to titrate up the medication. So just constant communication with families and educating them about end of life and the need for the medications to be given despite the side effects, actually, they really help. And I haven't really had any issues with families, accepting that, especially if they see that their loved ones are already suffering.
Thank you.
You're welcome. I think nobody else has any questions. No?
I don't see any in the chat box. So
Okay.
as you mentioned, if anybody has questions, I have Dr. Tenorio's cell phone number. I'm happy to get a hold of her or give
An
her
email,
number,
yeah.
or an email. So we thank you, Dr. Tenorio. We're glad to have you back. And we thank everybody for attending today.
Thank you so much. Bye.